All, this is Dr. Mobeen Syed from drbeen.com. Welcome to one more show. So, this discussion of can diabetes be reversed? Short answer yes. The second question is, do we have evidence to see this being reversible? Type 2 diabetes mellitus, I'm talking about, not type 1. The answer is yes. And then, how do we reverse it? I'm going to present that today. Today is going to be a little longer lecture because I'm going to go over the whole concept structures of what is diabetes mellitus, how can this be reversed, what is the evidence, and then briefly what are the mechanisms, and then the methods of reversing and various studies that have shown people reversing their type 2 diabetes mellitus. So what I'll do is I'll do a separate discussion in smaller pieces as well. And I also want to thank one of the anonymous cool beans who have invested 40,000 in Dr. Bean Corporation. And one of the series that she wanted us to work on was diabetes. I think that we should look at diabetes in general. And the reason I wanted to discuss was that I am becoming pre-diabetic as well, and my family, then my lots of friends around me. This age is such, so I think it is important for us to look at this. And I have a statement as well that I want to make, and tell me how do you feel. I think we should do this. These are gifts for humanity, and we should do this because your health matters. So with this, let's start. So first of all, references. This is Dr. Bean's. There's a link in the description for access to Dr. Bean. And as you can see, the price is really low. So take advantage of this. Then, and I'm going to close this. As you can see, the references are a lot. There is a slight thing I want you to keep in your mind when we are talking about this. That is this study. This is 2015. Psychological stress increases salivary alpha amylase. Salivary alpha amylase. So alpha amylase is an enzyme that is present in our saliva. If you can please keep this in your mind, because even after 1 hour of this talk, we're going to keep using it till the end. At the end of this talk, I want to present to you a few tips to see how we can start reversing it and what are the things that we should start doing as a lifestyle change. So keep this one in mind because we're going to talk about it. So stress increases salivary alpha amylase activity independently from plasma noradrenaline. So when we are under stress, it is supposed that in the saliva, alpha amylase increases, and in the blood, noradrenaline increases. Although they found out that salivary alpha amylase increases independent of the noradrenaline. Now, alpha amylase enzyme, its function is to break down carbohydrates into smaller pieces. It's kind of a scissor that breaks down long chains of complex carbohydrates into smaller and simpler forms that we can digest and eat. So you can think about it, why the stress will cause more salivary alpha amylase. Of course, because one, we're going to eat more, and number two, we want to have more energy because we're under stress. Maybe we have to go hunting. So we need these enzymes that will make the energy available to us. So here, these data suggest that in response to acute psychological stress, both plasma noradrenaline levels and salivary alpha amylase reflect sympathetic activity, however, seem to increase independently from each other. So keep this in mind, please. Now, I want to start from the Frederick Banting. So Dr. Frederick Banting was a Canadian medical scientist, physician, painter, Nobel laureate. He is actually a co-Nobel receiver for the discovery of insulin. Now, American Diabetes Association gives the Banting Award to someone who has a long-term contribution to diabetes reduction or management of diabetes. And do you know that Banting was and is the youngest Nobel receiver? I think at the time of Nobel Prize when he was 32. And since then till now, there has been nobody this young who got Nobel. Then I want to introduce to you Barbara E. Corky, PhD. She is in Boston University, and she is the, I believe, if you look at it, Dr. Barbara Corky is emeritus professor of medicine and biochemistry. Her work is really, it shines for her work for diabetes. However, this one lecture or this one talk or this one article that she presented in 2011, Banting Lecture 2011, that means she was given by the American Diabetes Association the Banting Award. And the title here, check this out, Hyperinsulinemia, Cause or Consequence. So I want to start from here. And I'm going to, for a second, see if I can. I'm so sorry that the mouse does this. I need to change my hardware. Anyway, so very quickly, generally we think that the progress to diabetes is we eat carbohydrates. Eventually, what happens is we eat so much that we start making fats. Fats become accumulated or stored on our various body parts, men mostly abdomen, women hips and thighs as well, although visceral fat is also possible, and that is also mostly in men. And I would take hip and thigh fat anytime over visceral fat because visceral fat is much more dangerous. And then we say that the fat would make inflammatory mediators because it is actually a big organ. It is an endocrine organ, not just a storage space, and it would create inflammatory mediators. Those mediators would go and cause inflammation throughout the body. As part of that inflammation, the cells of the body that are under attack by the inflammatory mediators coming in from the fat tissue, these cells will become insulin resistant. So when they'll become insulin resistant, then there will be insulin present, there will be glucose present, but the cell will not pick it up. And now the cell is starving and the glucose is just roaming around outside. That glucose that is roaming around outside is now getting stuck to various tissues. That is called non-enzymatic glycation. Again, today's talk, I want to stay at a high level to actually describe the mechanisms instead of draw them. I think if I drew this whole lecture today, this would be about 10 hours or more. So we'll do a series separately. So the glucose that is present is now getting stuck like mud on various tissues and making them dysfunctional or disrupting their function, causing inflammation. And then glucose enters various tissues as well, for example, nerves and blood vessel cells, eyes, lenses, and so on, whichever tissue it can go to. And it causes osmotic pressure in there. It pulls water with it. That causes the cell to swell up, and they pop and they burst and they break. And that is a problem. Then in some tissues, it becomes sorbitol. Then that sorbitol cannot get out of that tissue. And now the sorbitol is accumulating and the cell would pop because of that as well. So these are the kind of damages glucose does. This is the normal. Sorry, one more concept here. And as the body tries to cope or handle this situation, body releases more and more insulin so that glucose can get into the cells. The continuous production of insulin by pancreas eventually causes the pancreas to become burnt out, which would then cause the type 2 diabetes would become converted to insulin dependent type 2 diabetes mellitus. This paradigm, this set of concepts to explain what diabetes mellitus is, has been out there for a very long time. And the management is also aligned to this paradigm. In this paradigm, we say that there isn't enough insulin to help glucose get into the cells, and that is a problem. So we keep providing things that would increase insulin. Although nowadays we also are looking at drugs or we are administering drugs that would stop, and it's not nowadays, it's been for some time, that would stop glucose absorption or that would throw glucose out. So these are recent drugs, SGLT2 inhibitors, that would throw glucose out through the urinary pathway. So in addition to insulin, now we are trying to reduce the glucose levels. So this is the concept set. I want to now go to Banting lecture and present to you that how she put this whole set of concepts on its head. These concepts were then picked up by many other presenters, many other good doctors, Dr. Jason Fung, Dr. Ben Bickman, and many other who have been talking about it and are tremendously helpful to humanity. So let's look at what Banting lecture and Dr. Barbara Corky said, and then we'll continue with our discussion. So Dr. Corky, let me open her PDF as well. She said that basically it is not that we have been eating more glucose, producing more fats, which cause hyperinsulinemia. Instead, now check this one out, and if you have your paper and pens, we are going to start having the lifestyle changes from now. Instead, she said, it is the reactive oxygen species that are produced more in our body, which lead to beta cell producing more insulin. So if there are more reactive oxygen species produced in the beta cell, they would produce more insulin regardless of the glucose's levels. So this is the first paradigm or concept break that I want to present to you. We used to say the amount of glucose would drive the amount of insulin. That is still true. However, even in the absence of glucose, insulin levels can go up if we have eaten kind of foods that would cause reactive oxygen species production. And let me just very quickly show you. And remember, this is not a fringe doctor with a fringe concept set. She was given Banting Award by American Diabetes Association. So it's a very important set of concepts. So if you see here, she says some factor X something, that when acts on the beta cells, and imagine that factor X can actually be acting on all of our cells, and it causes reactive oxygen species to be produced in all the cells. However, beta cells are the one that are related to diabetes, so we're talking about that. So when factor X acts on the beta cells, beta cell in response become hyperactive and hypersecretory, and they start producing insulin. Now we are in a hyperinsulinemic state. Now that hyperinsulinemic state is the driver to start causing insulin resistance. This is a very important change in the paradigm. Hyperinsulinemia, hypothetically in her paper, is causing insulin resistance. That means this problem to solve, that how do we become insulin resistant, which the other paradigms have still not proven. And I would show you today that there are papers, there are articles that say we do not know how we became insulin resistant. So here is a paradigm shift. She says bring in something that would cause reactive oxygen species production, which would in turn cause more insulin. More insulin, think about it for a second with me. If your body, I'm so sorry, I changed my setup and so my monitors are all over the place. If your body produces more insulin, what will happen to your glucose? The role of insulin is to push glucose in the cells. So whatever glucose is present in the body, in the interstitial tissue and in the blood circulation, insulin is going to push that glucose in the cells. So tell me this, what will happen to the glucose levels in the blood circulation? It will reduce, correct? And if we have hyperinsulinemia, too much insulin is present, Wouldn't that insulin pick up whatever glucose and just throw it into the cells? Wouldn't that cause hypoglycemia? That is what happens as well. If you give more insulin than needed to a patient, they would become hypoglycemic. So, if our own body, in response to some foods, is making too much insulin, wouldn't that push a lot of glucose back into the cells? I hope you're saying yes. And now here's the problem: hypoglycemia can kill us, can cause brain damage, can make us unconscious, can really, really be dangerous. So, our body, according to Barbara, our body has created a homeostatic mechanism, a response mechanism to this. That mechanism is that the body says, you know what, too much insulin around me, I am going to reduce the receptors that respond to insulin so that I do not accidentally end up in hypoglycemia. And it makes sense compared to saying we have no idea how insulin resistance occurred, but it occurred. That is the other paradigm. In this paradigm, more insulin became dangerous. Just like if we take more nicotine, daily our response to nicotine would start reducing. That is, we are adapting to it. And one way to adapt is by down regulating the receptors that respond to nicotine. We do this to almost everything that we take in abundance. That is one thing that hyperinsulinemia would do. The second thing it would do is it would start depositing over time if your insulin levels stay high. See, I'm not even talking about the glucose levels. If your insulin levels are staying high, our body would start producing fat, which it would produce because when the insulin levels are high, will push the glucose in the cell. Then there will be enough glucose in there that they cannot have more glucose. Then we'll start converting the remaining glucose in the fats. Liver will become fatty, and then pancreas would become fatty. So this is also a theory. It is called a two-circle theory that was postulated by a physician, and I think another 10 years ago. It is interesting that these thoughts, these concepts have not been brought out in the mainstream, and whatever is the reason for that. But I am actually very glad that American Diabetes Association is actually presenting these evidences on their side. And not only that, they are actually giving awards for these messages. So the two-circle theory is that the first, liver will become fatty, then the fats would start spreading in the body, and pancreas would start becoming fatty. The point of fatty pancreas is the body's homeostatic mechanism to try to bury the pancreas in fat so it does not make more insulin. So body says, man, you are just continuously making insulin. We do not need so much insulin. You're going to push so much glucose in the cells that we will go in hypoglycemia. So stop doing that. And when pancreas doesn't stop doing that, body would just deposit fats in there. That is also a protective mechanism to try to stop pancreas from producing too much insulin. Guess what? If you want to reverse this diabetes, what would you do? Why there is diabetes? Because the body has become insulin resistant. That means there is more glucose just sitting around. What do? You remove the fats so that the fatty pancreas is reversed and normal insulin levels will start forming again. So this is the basic theory behind Dr. Corky's message, this paper. So if I go to the end of this paper, she says, in this conceptual model, insulin resistance is caused by hyperinsulinemia and is an appropriate adaptation to the increased need to store fat in adipose tissues without causing hypoglycemia. This one statement is the key for all modern diabetes management processes, not mainstream, but some of the intermittent fasting and other controls that we are talking about. Dr. Fung is talking about it. Dr. Ben Bickman is talking about it, and many others. This one statement is the grounds for that work. And I'm going to read it to you once again. In this conceptual model, insulin resistance is caused by hyperinsulinemia and is an appropriate adaptation to the increased need to store fat in adipose tissue without causing hypoglycemia. So we do not want to produce hypoglycemia, so we take the glucose and store it in the fats. Now, I missed one part deliberately. It must be in your mind right now, and that is, what is the factor X in this paper? What does she think is going to be causing this? And so that is a whole paper. What she talks about is, are environmental factors, including processed food, including preservatives in the food, including contents in the food that we do not even know the behavior of that content in our body. Those contents, she tested some of them, cause insulin secretion even when there is no glucose levels that are higher. So this is an important concept to decouple in your mind. Our thought so far is more glucose, more insulin. I want to decouple that in the light of this article, and that is, no, it is not necessary. You might actually eat something that would have some ingredients that might actually cause reactive oxygen species to be produced, which in turn would cause insulin secretion, which would cause hyperinsulinemia, which would then cause insulin resistant, and voila, we got more glucose, we got more fats, and we are in trouble. Once that happens, then it becomes continuously maintained. Why? Because now the fats that are produced are actually producing the inflammatory mediators, and now they are also helping produce insulin resistance. And now we are stuck in a cycle. So I want to show you something. I'm going to keep closing them because my computer is under pressure with all of these open things. So I want to show you one more thing. Check this out. This is 2019, April 2019. Glutathione prevents chronic oscillating glucose intake induced beta cell differentiation and failure. Glutathione, it's a precursor to NAC, N-acetyl cysteine. Glutathione, you can also think of it as a reactive oxygen species scavenger. I've done a discussion before. You can search for glutathione within my lectures and you can see how it works. Here, in this beautiful paper, what they proved was that if you see here, this one, LOSG, this is the long-term oscillating glucose. They say that nowadays our body's behavior, our feeding behavior, is equal to long-term oscillating glucose. That is, we eat in the morning and then again and then again and then again, and we do snacks and we do all of those things. So there is a continuous oscillation of glucose attacking our body. So they say that when there is long-term oscillating glucose 4 times a day, beta cells start becoming impacted. They start remembering that there is higher glucose. They start producing more insulin. They start failing. And guess how did they protect? This is an animal model, not human model. They gave these animals glutathione, and they totally reversed the effect of glucose that was creating insulin levels. So that means any other thing that would produce reactive oxygen species, glucose does produce reactive oxygen species as well. We know that it is pro-inflammatory. So this is another important thing to keep in mind. So with this, I'm not finished yet. I'm only started. So my apologies for this Let's start with my presentation. So we are starting now. Is type 2 diabetes mellitus reversible? So structure of our talk, and I do not have any conflict of interest if it is going into the CME lecture. Structure of the talk is we'll talk about insulin resistant and hyperinsulinemia, cause or consequence. I've already talked about it. Overflow versus underflow theory. I don't think I have time today to do that, so I'll leave that for today. How bariatric surgery or stomach bypass surgery helps recover from diabetes. So in this one line, I want to break another concept, and that concept is generally we say that if you lose weight, you become diabetes free or intensity of diabetes becomes less. I want to show you that when the bariatric surgery is done, when the stomach bypasses are done, the patient has not yet lost weight. Even then, they become negative for diabetes within days. And the question in our mind should be, what happened? They haven't lost the weight yet. Why are they becoming non-diabetics? If it is the weight that is going to help reduce diabetes, which it does, but if it is just that, that means after bariatric surgery, after somebody has gotten their stomach tied up or their bypass surgery done for the stomach, then when they will become thin, which could be many months, then their diabetes should become better. But you would see, I'll show you the evidence that the diabetes mellitus type 2 will become better within days after bariatric surgery. So question is, what happened? Did the patient just lose all the weight within days? So I'll discuss that. Then American Diabetes Association and their approach towards diabetes remission. I'll show you that. And then various therapies that people have used to cause remission, including Dr. Jason Fung's approach. Of course, he has written books. I cannot present them all over here. I would request you to watch his videos and read his books, but I'll present you the core of his methods as well. And then finally, if we want to do some question answer, I can come back and do that. So let's start. Hyperinsulinemia, I have already done this, so I'm not going to do this again, but I'm going to present to you mainstream article here that says, check this out, what causes insulin resistance and pre-diabetes? And look at the answer. This is the mainstream answer. Researchers don't fully understand what causes insulin resistance and pre-diabetes, but they think excess weight and lack of physical activity are major factors. So we do have in our, if we read the pathology books or if you read various articles, you would read that in those places it says that the inflammatory mediators coming off from the fats, they can do this. Then PPAR gamma receptor, secondary messenger system of this receptor system, that is something to do with the resistance and so on. There are many theories that are present, but eventually we do not know what causes insulin resistance. The reason for that is we continue to ignore this, that before a person becomes pre-diabetic, before a person becomes diabetic, they were already insulin resistant. Who, if we looked, how did they become insulin resistant before they became diabetic? That is the time to understand the mechanism. And that is the mechanism that Dr. Barbara Corky's paper alludes to. And that is the mechanism that I'm going to present to you. And that is hyperinsulinemia instead of hyperglycemia. So this is the mainstream saying, hey, we don't know. And the conjectures are not getting enough physical activity is linked to insulin resistance and pre-diabetes. Sure, we should move. And I have done this discussion before, that muscles have sensors within them that when the muscle cell stretches and skews and moves, there are microtubular infrastructure within the muscle cell that gives the muscle cell a shape. When those things, those pillars, they move, there are sensors attached to the angles of the pillars that would cause the GLUT4 receptors or glucose transporters to move up to the cell membrane and pull the glucose in regardless of the presence of insulin. This is insulin independent mechanism. So whenever you walk or run or exercise, you will pick up insulin. So that is a completely important thing. So if you're not doing a lot of physical activity, then of course you're not using a lot of glucose. So then next, we just talked about Banting lecture by Dr. Korki. I'm not going to go into this once more. Then the solution now, I hope that this becomes important and clear to you, that the insulin resistance is not because of more glucose and fats. Instead, insulin resistance is because hyperinsulinemia, when there is more insulin, that causes a downregulation or adaptive response of the body or homeostatic response of the body. And I hope that this is also clear that what may be causing hyperinsulinemia is the kind of foods and the preservatives and the elements in the food that we have never looked at to say, what are these elements doing in the food? And if you compare ourselves to people before us, centuries before us, or even 50, 60 years before us, they were eating kind of foods which didn't have so much preservatives. They were not processed foods. They were not packaged foods. And they didn't have the epidemics of obesity and diabetes as we have. And regardless of all the medicines that are available to us now, we still continue to have obesity and diabetes. And that is because our foods have problem. So then our current way of managing is that we give drugs, we give more insulin, we try to use low fat diets, we try to do everything to increase insulin so that glucose can get into the cells and we can get rid of the glucose. Of course, we also say that, hey, take less carbs. But this is the approach. So we are really managing hyperinsulinemia, more insulin with more insulin. So we keep making things bad and then we say, well, this is a chronic progressive disease. On the other hand, if you see people who are remitting, and we would see them today, those in remission actually do everything that reduces insulin levels. So bariatric surgery is one. I'm not saying everybody does a bariatric surgery, but we observe it in them. Then fasting, especially intermittent fasting, and then very low carb diets. In fasting, the insulin levels go down, and that's what I want to show you. So let's go. If you treat your diabetes with the mindset of reducing insulin levels compared to reducing glucose levels, you will do all the right things that are necessary to remit diabetes or go into remission. Right? So let's see. Evidence of remissions. This is a study. The study is bariatric surgery for type 2 diabetes reversal. It has been over 10 years since, and this is 2011, it has been over 10 years since the resolution of type 2 diabetes was observed as an additional outcome of surgical treatment of morbid obesity. Moreover, it has been shown unequivocally that diabetes-related morbidity and mortality have declined significantly post-operatively, and this improvement in diabetes control is long-lasting. Bypass procedures, so we're talking about stomach, bypass procedure, the Roux-en-Y gastric bypass or RYGBP, and the biliopancreatic diversion are more effective treatments for diabetes than other procedures and are followed by normalization of concentration of plasma glucose, insulin, hemoglobin A1C, 80 to 100% of morbidly obese patients. And if you look at the data that is presented in these studies, the patients start becoming euglycemic and start having no diabetes or start quitting medicines for diabetes because their insulin requirement is gone within days. They still have the weight on, Studies have shown that return to euglycemia and normal insulin level occurs within days after surgery, long before any significant weight loss takes place. So, if the concept is that weight loss will reduce the fats, which will reduce inflammation, which would cause less inflammation to the cells and more insulin responsiveness, that whole concept does not fit into this observation. So I want to read this once again. Studies have shown that return to euglycemia, normal glucose level, euglycemia, eu means true, the right glucose level, and normal insulin level occur within days after surgery, long before any significant weight loss takes place. So how do we explain that from our mainstream paradigm? Mainstream paradigm, reduce your weight, then you'll become fine. That would also help. But here, what is going on? Weight is not reduced. Do you know what is going on? Patient is fasting. Patient is unable to eat food or enough food. They're really doing intermittent type fasting. It is the fasting that is reducing insulin. And if you said, why would fast reduce insulin? Well, if you're not eating any processed food or any food at all, where would the insulin come from? What would trigger the insulin? Nothing. And when the insulin is not triggered, then the insulin resistance would go away. When the insulin levels will go down, our cells will become responsive. Just like when you quit smoking or when you quit taking coffee, your nicotine receptors would go back up. So when you have less insulin, then the receptors would upregulate again. And even with the normal insulin levels, they would start working correctly. Insulin resistance would go away. One more study, bariatric weight loss surgery for treating diabetes. Weight loss surgery, also called bariatric surgery, can be done in minimally invasive ways and can be used to treat type 2 diabetes. So look at this. Doctors have found that weight loss surgery can treat type 2 diabetes by managing the level of sugar in the blood. And eventually, it is really coming from the insulin's level changes. So what we are putting the whole paradigm on its head, and I'm presenting to you the evidence. And this is mainstream evidence. The evidence is in the mainstream. Solutions have not yet made mainstream. Now, how does American Diabetes Association take a stance on this one, which I really appreciate? Normally, organizations, as we have seen, sometimes are just not properly responsive and they're captured. They're just not inclined to look at other things. So look at this one. This is ADA. Nutrition therapy for adults with diabetes or pre-diabetes, a consensus report. This is 2019. In 2019, American Diabetes Association, in concert with other associations, came up and said, we think diet can help control diabetes. So here is dietary medical therapy instead of give this drug or that drug. And in this one, there is a very interesting paper. So let me show you that as well. This was Barrington, bariatric surgery. So if you go here in this paper, all links are in the description, except the link to that psychological stress and the alpha amylase. In here, the table number 3, this table, excuse me. In this table, they're talking about what are the lifestyle of a specific patient or person who is diabetic and what kind of food changes to ask them. So this is a progress, although in my opinion, they miss the point that to reduce insulin levels, it's not just the carbs to be changed, It is the foods that cause insulin levels to increase, which can be more than glucose foods because of the preservatives and because of the processing and because of the weird ingredients nowadays that we have in our food colors, etc. Actually, if you uh, read the Barrington Lecture 2011, she has listed out certain components of the food that can cause reactive oxygen species and cause pancreas to produce more insulin and put the whole diabetes problem in motion. We become diabetic by our food. And then we got stuck because our body starts making fats, which would then accentuate and maintain the diabetic state. And we can come out of this by food. It's just that now we have to reduce our food. Okay, so this is one more. Continuing. Then this is 2021. 2021. So 2011 was when Dr. Corky gave that theory or model paradigm. 2021 is when ADA said international experts outline diabetes remission diagnosis criteria. You cannot you cannot write an article in a mainstream associations area for something that is not possible. So if they're saying diabetes remission diagnosis criteria, then of course it is possible. That's why they wrote it. So let's see what is that criteria. This is that article, and here are their points. Number one, remission should be defined as a return of hemoglobin A1C to less than 6.5% that occurs spontaneously or following an intervention and that persists for at least 3 months in the absence of usual glucose lowering chemotherapy, meaning pharmacotherapy, meaning you're not taking any medicines. Medicines are withdrawn and you still have the normal hemoglobin A1C. I would actually extend this one. I think that there is a mistake in this one, and that is the following. Imagine for a second that we had done all of this food eating for our whole life, and we produced lots of reactive oxygen species. We caused fat deposition, we caused glycogen deposition, and we have filled our body with those things. Now we started doing intermittent fasting or whatever we did, and our hemoglobin A1C started going down. We had less carbs, we did exercise, we did intermittent fastings. When we hit hemoglobin A1C, that means we have kind of gone back towards the normal, but that doesn't mean our body is still not containing all those things. It's just that these are in the lesser levels. If you start eating again, thinking I become as normal as I was in 20 years of age, then in a few days, you'll start becoming diabetic again because you haven't yet fully finished the stores. So staying that way for 3 months simply means you have developed habits that are maintaining that level. But if you developed habits, let's say intermittent fasting or caloric restriction or some other process, exercise, no carbs, and you reached hemoglobin A1C, you said, well, I am good. And you stopped those exercises, you stopped those methods, you will become diabetic again because it's a diet problem. That means maybe you do not have to be as rigorous as you were when you were becoming or moving towards remission, but you would still have to be careful because you still are full of those glycogens and fats and other things. But if you keep taking care of it, then you would slowly continue to empty. You took decades to fill these things. You would continue to empty them over the years as well. I would love that by my 70s, 80s, I have emptied enough that even if I ate whatever I wanted, I would not develop diabetes right away. These are the possibilities. So number one, they say remission should be defined as return of hemoglobin. Number two, they say when hemoglobin A1C is determined to be an unreliable marker, And the reason, excuse me, some patients who are sickle cell anemic patients, their RBCs, they cycle within, let's say, 1 month or 1.5 months, some even 20, 30 days. So you cannot use RBC, red blood cell, to give you an idea of 3 months of glucose because the RBC is destroyed within a month. So such RBC cannot tell you reliably hemoglobin A1C level, which should be 3 months measure. So in that case, you'll have to look at the fasting glucose levels. And if they are lesser than 126 milligram per deciliter or lesser than 7 millimoles per liter, or estimated hemoglobin A1C is 6.5, then you are once again good. In my opinion, what Dr. Paul Marek did is what we should do. He put on the continuous sensor. Now, continuous sensor is anywhere from $80 to $700. I found some sensors that are $120 and are decent. I'm actually going to use them as well. Even if my insurance says you're not diabetic, we're not going to cover it, to see how does my body respond to various kind of foods and what kind of spikes do I develop. And the best thing should have been that we should have, just like home glucose meters, we should have home insulin meters. As soon as we have the home insulin meters and we know what causes insulin to spike, we would not have diabetes in the world again. And that is a great product idea as well. If somebody wants to do that with me, we can do this. Okay, then number 3, testing of hemoglobin A1C to document a remission should be performed just prior to an intervention and no sooner than 3 months after initiation of the intervention or withdrawal of any glucose lowering pharmacotherapies. Meaning, if you're going to say that, hey, I'm going to do intermittent fasting, then you start testing afterwards, and so on. So these are their criteria. The point of this is not to read the criteria to you, but the point of this is it can go in remission. That is why these articles are out. This is 2021. And Barbara, I wish I could go and shake her hands for her contribution. Barbara's contribution towards hyperinsulinemia, maybe the cause of insulin resistance, is huge. This whole thing is now developing on that paper. And then I forgot the name of the second gentleman who gave the 2-circle theory, that first you get fatty liver and then you get fatty pancreas, and you have to remove the fats from the pancreas to have it back towards normal. I forgot his name, but that is an amazing theory as well. Okay. Then what are the interventions? How have people done remission? So I want to show you various studies. There are many ways to reach remission. There are traditional ways of waiting to lose weight and then seeing if we can become euglycemic. But you know that I'm going to make a statement. I hope it would make sense in the context of this whole thing. If we eat even a tiny bit of a food that causes insulin spike, then we will not lose weight even if we are eating lesser calories. And this is a very strange statement. And I've seen this kind of a statement getting attacked so much from the mainstream. And here is the attack to it. I'll put the attack in front of you already. The attack is, how can somebody have less calories and still not lose weight? And the answer is actually very simple. What happens is, if you have insulin is a hormone whose function is to switch the body into storage state. Less insulin switches the body back into consumption state. And consumption of what and storage of what? Fats, glycogens and fats. So when we have insulin, our body presumes that insulin more means more glucose. And so the body becomes ready to receive the glucose, use that up for the activities, plus make glycogen, which is stored form of the glucose, plus extra glucose goes and becomes fats. Everything is store, store, store. This is why actually after you eat food, you become all lethargic and slow, which is called the food coma or alkaline tide. One of the reason our body does that is that body knows you just ate food and now it wants to pick that up and store it everywhere. It doesn't want you to start moving about and using it. So when insulin is present, body is in storage mode. When insulin is less, body is in consumption mode. It would take the glycogens and break them up and use them. It would take fats and use them, and that is a consumption mode. Now, if we are eating less, so let's say my need for total calories, there is a basal metabolic rate and then there is calories on top of that. Basal metabolic rate is if I'm sleeping somewhere all the time or just lying down, even then I need energy to operate my body. And then as I'm active and working, and right now I'm talking and I'm animated, all those need extra energy as well. If I do exercise, there's more energy as well, and so on. Let's say you only my total need is, let's say, 2500. My basal metabolic rate need is 1500. I'm making up numbers. You give me less calories. You give me, let's say, 2000 instead of 2500. It is not necessary that right away that extra 500 will be removed from fats. In fact, body would take that from glycogen and then it would take that from fats if necessary. But body would do one more thing, and that is it would reduce its metabolic behavior. As soon as it reduces its metabolic rate, it reduces the consumption. And when it reduces the consumption, you feel really bad. You would feel tired, you will feel disoriented, you would feel really not great. But if you had eaten those 2000 calories instead of 2500 calories, if you had eaten carbs in there, they have produced insulin, or if you had eaten foods that were insulin triggers, that insulin is not going to let you pull things out of the storage. Because insulin produces storage, it does not reduce storage. In the presence of insulin, you cannot take things from the storage. Imagine if somebody is standing in front of the kitchen and saying to you that if I am standing here, you cannot get food from the kitchen. Go get it from outside. That is why sometimes when we do portion controls or caloric restrictions, that doesn't give us that fast a solution because insulin is still present. Or that is why sometimes we start bouncing back. We become resistant to weight loss. We say we are doing everything for the weight loss and we are still gaining weight or maintaining weight. And the reason is that body adapts. So in these methods, you would see that there are more innovative methods that are aligned to this paradigm of more insulin. So let's see them. Here is one: nutritional basis of type 2 diabetes remission. In here, they're saying dietary restriction through eating strategies, portion control. So in this one, they have multiple strategies they put in front of you. Portion control is an established strategy for weight loss. Daily, now check this one out. Daily alternate day fasting aims for roughly 25% lower intake of food energy. Now, fasting has a weird outcome, and that is weird in a good way, that you actually have nothing. There is no preservative, there is no processed food, there is no complex food, there is no carbs, there is no idea of proteins or fats, there is just nothing. So insulin has to go down. And when insulin has to go down, then your body has to figure out that how am I going to maintain this huge body for the whole day without food? Where am I going to go get the energy from? And it would first pull that from glycogen. I'll show you a study where they showed that the first 3 days, I think that was an NIH study, first 3 days the food was taken from glycogen stores, then fat stores. And this idea that the muscle would start breaking, that's actually incorrect. Muscles are not used up until we are 10, 11 days in continuous fast. For example, people who are lost in deserts or in valleys or in jungles or in mountains, and they have no water and no food and they're just continuously starving, their body eventually starts eating up the muscles too. But as long as we have fats, we're not going to touch our muscles. So intermittent fasting, roughly 25%. So 5-2 is 5 days regular food and 2 days of 5 to 700 calories. So if you see, this particular study does not talk about full fast, no food at all. They are still giving you 500 to 700 calories, which is really below the BMRs, even BMRs need. We need more than BMR, but even BMR usually our requirement is 1200, 1500, 1700 or so. So of course, this would put the body in a deficit. Now, if these 5 to 700 calories have carbs in them, then you're going to produce insulin. You're going to fight with your body to not take the storage out. Now, body is hungry. It wants to take the storage out, but you have put insulin on top of it as a regulator to say no storage to be touched, and you're going to feel bad because you don't have energy. So this kind of diet restriction has that possibility. Okay, then this is that two circle theory. So if you see here on the left side, and all references are here, type 2 diabetes, liver fat increases, then fat comes out of liver, then the pancreatic fat increases, and then pancreas doesn't work correctly. And then when you're going in remission, whoever, then the liver fat reduces, fat in the body reduces, pancreatic fat reduces, pancreas becomes normal and starts functioning again. They say that at least within 10 years of developing diabetes and being on diabetic medicines, within 10 years, if you do this intermittent fasting, you actually bring your pancreas back towards a normal function. So that idea of pancreatic destruction doesn't even hold. And I would show you Dr. Jason Fung's study, in which he had 3 patients. It's a very popular study, so you must have seen it. He had 3 patients on insulin for 20 years, and they had remission and they started producing insulin again. Method 2. So this was the previous method, was intermittent fasting, but not full fasting. There was 2 to 700 calories still being given. Method number 2, intermittent fasting with low carb diet. I believe this is Jason Fung's. Yes. So Suleiman, Fermili, Rami, Megan, and Jason Fung. Therapeutic use of intermittent fasting for people with type 2 diabetes. So in this one, what they actually did was they reduced. So basic method here was one day dinner, other day lunch and dinner. That was the basic setup. Some patients did 3 days of dinner only and the remaining day. So today dinner, tomorrow lunch and dinner, then lunch and dinner, then dinner, and so on. Then lunch and dinner, lunch and dinner. So they made this structure, plus they reduced the carbs. So really the idea was to provide 24 hours of fasting at least on one day and have such days. Check out the results. So look at the patients first. Table 1 of the study, there were 3 patients. It's a case series. It's not a randomized control trial. It's a case series. 3 patients. One was diabetic for 20 years, other diabetic for 25 years, another diabetic for 10 years. They had hypertension, hypercholesterolemia, and I want to tell you something. Hyperinsulinemia can cause hypertension because insulin, independent of the glucose mechanisms, can act on the endothelium and cause the, the blood vessel to modulate. So, somebody who is developing a tummy like I am and then develops hypertension as well, which I have not yet, is actually a possible candidate to check their insulin level because this may be hyperinsulinemia before diabetes has occurred, which has caused hypertension. In such patients, usually doctors' approach is they're going to start treating hypertension. But I wish they check their insulin levels as well. And if they find hyperinsulinemia, then they treat that aspect before they treat hypertension, and the hypertension would go away. So here, if you look at the patient's hypertension, hypercholesterolemia, chronic kidney disease, renal cell carcinoma, hypertension, hypercholesterolemia. What was the method they did? Patient number one, 3 times intermittent fasting, week for 7 months. So that was dinner, dinner, lunch, dinner, dinner, lunch, dinner, dinner, lunch, dinner, lunch for the rest of the week. Second patient did the same for 11 months. Third patient, alternating days for 11 months. All patients followed similar dietary regimen. So on fasting days, the patients only consume dinner, whereas on non-fasting days, the patient consumed lunch and dinner. Low carbohydrate meals were recommended. Good. I hope that my mic is actually working. So let's, if it is not working, hey, I've spent an hour talking to the camera. Okay, back here. Can you hear me? I have a new mic, so I have no idea if it is working. So I'm looking at the, yes, we can hear you. Excellent. So back here, results of the study. Patient one, that patient was on insulin, glargine, aspart, canagliflozin, metformin. That patient came off of insulin within 5 days. So this flies in the face of the idea that the weight loss would cause remission. Nobody's going to lose all their weight within 5 days to become insulin, non-resistant or free of diabetes. So 5 days, insulin is off. Then this patient had to stay on canagliflozin. Other patient, patient number two, 18 days off of insulin, then never any other medicine. Patient number three, 13 days off of insulin and then no other medicine ever. They became diabetes free. So this is the second method. What's the difference in the first and the second method? First method was giving 500 to 700 calories on the day of fast. So they were still giving food. The second method is 24 hours of free, no food, and then dinner. So that was still a 24-hour long nothing. Now, method number three. This is, I love this one. This is from Unwin's and Ali Hassan and Jen Unwin and David Unwin. This is from UK. This I really, out of all the methods, I loved this one because of their preparation for patient, their preparation of how to educate their patient. So what they did was, this was a clinic. There were about 9,800 patients, and they would ask those patients between 2013 and 2019 to participate in diet education and taking diets that would reduce glucose and insulin. And they had, in the process, I think a few hundred patients became involved, not 10,000. So those who became involved, 46% became remitted. 46% diabetics in a clinic became remitted. That's a big deal. Normal clinics do not even have 1% remit. They just keep giving them more drugs and more drugs and more drugs and then insulin. Here, 46% became remitted. And number two, those who were pre-diabetic, 93% of the pre-diabetic actually went back to normal instead of becoming diabetic. So if you see here, the median hemoglobin A1C dropped from 65 to 48. So 65.5 millimole per mole is kind of near 7.8, and then 48 is 6.5-ish. And p-value is 0.001. For patients with pre-diabetes, again, it dropped from 44 to 39 and 0.001. Drug-free type 2 diabetes remission occurred in 46% of participants. In patients with pre-diabetes, 93% attained a normal hemoglobin. This is one of their diagrams where they show that here is the kind of chart we gave to the patient to say, look, this is the glycemic index. For example, if you take basmati rice, then, and basmati rice, Pakistan's basmati rice are the best. So here, it is equal to 10 teaspoons of sugar. So the glycemic index is 69, potato, and so on. So they gave them these. And now that we're talking about this, I'll tell you a little tiny thing to consider. If you are going to eat carbohydrates, I love rice and I eat them even when I'm fasting, it's 19th day. Take a tiny bit of acid with it. We, in our culture, we take pickles. So take some pickle or vinegars or any other thing that is slightly acidic. And what that does is, remember we talked about alpha amylase of the salivary system. Acid neutralizes the alpha amylases. And now for those medical students or professionals who are saying that salivary alpha amylase is not important, pancreatic alpha amylase is more important, they are kind of not fully correct. For the carbohydrates, 70% of the breakdown process starts with the alpha amylase in saliva. So if you have kind of neutralized the alpha amylase in the saliva, you actually reduce the glycemic index of these foods because they still have, when they reach our intestine, they still have larger chains of glucoses and or sucroses. And the result is they cannot readily give small glucose molecules. And in some cases, the index falls by half. So you could take rice and kind of reduce their glycemic productivity to half by just adding some pickle or vinegar or other acidic things. Lemon. This was a chart that they gave to their patients. And they said, look, eat blueberries and strawberries and raspberries. Remember, Dr. Paul Marik has been talking about this as well. Eat apples, eat pears, but don't eat too much of the other fruits that can add a lot of glucose or fructose actually. Similarly, they talked about the green vegetables and fruits, what kind and so on. So I would actually recommend that please look at it. This is also, the link is in the description. And here is the, look at this. Imagine if this was 100 was the hemoglobin A1C at the starting. So initial hemoglobin. And this is the target, where did they end up, the decrease. So from the people who were at 100, they actually ended up, if you see here, some ended up near 38, so even below normal. Some were here, let's say 40, 50, 60, so almost normal. 48 is normal. So 100 down towards normal just by taking care of food. So they did not do fasting. They just asked them to take care of the food. So now we have three methods. Portion control, 500 to 700 one day calories. Second type, intermittent fasting, 24 hours of nothing. Then third, low calorie diet, normal one. So primary care led weight management for remission of type 2 diabetes and open label cluster randomized trial. This is the last one. So I'll leave you off to this one. I know it's more than an hour. Weight loss was induced with a total diet replacement phase using a low energy formula diet. So this was a beautiful study. What they did was they had the patients for whom they wanted to have weight loss and diabetes to go away. They started them with the 825 to 853 kilocalorie per day. That's for 3 months. If somebody said to me that you're only going to eat 800 calories per day for 3 months, I'll probably start crying. So 59% carbs, 30% fat, 26% protein, 2% fiber. So this one has nothing to do with less insulin, just very tiny amount of a portion for 3 months. Then it could be extended to 5 months. Then after that, they started reintroducing normal foods for 2 to 8 weeks, back to 50% carbohydrates, 35% fats, and 15% proteins. Guess what they got? Check this out. At 12 months, we recorded weight loss of 15 kilogram or more in 36 or 24% of the patients. Diabetes remission was achieved in 46% participants in the intervention group and 6% of the placebo. Then, couple of two things. One, there is this idea that if you're fasting, I'm fasting, this is 19th fast. If you're fasting, you are low on energy. I hope you don't see me low on energy. Actually, I'm more animated than normal days. So resting energy expenditure. This is an Oxford study that when somebody is fasting, their energy level actually goes up. The reason for that probably is that imagine if we were cavemen and sitting in a cave and we haven't eaten, what does that mean to our body? This guy was not able to hunt. And if he's not eaten food, he's not hunted, he is going to die. So what would the body do? It would quickly produce norepinephrines, stress hormones, plus it would mobilize the fats or whatever storage it has to give you the energy to go hunt. So during the fasting, body actually, out of the panic that what happened, it actually moves more fats out in its effort to help you become mobile to go get some food. So when you want to melt away your fats, fasting is the best mechanism because fasting does not reduce the utility of calories or does not preserve the storage like low calorie diets do. Instead, it actually gives you more and in that process removes more fats. So if you see here, results, resting energy expenditure increased. So they're talking about the fast significantly. So let me actually show you the design. Resting energy expenditure measured by indirect calorimeter and hormone and substrate concentration were measured in 11 healthy individuals lean on day 1, 2, 3, and 4 of an 84-hour fast starvation period. 84 hours. So you would think that, all right, maybe the first day there was more energy and the last day there was not. Actually, energy expenditure kept increasing. The body kept saying, go get food. I want to give you energy. So resting energy expenditure increased significantly from 3.97 plus minus 9 kilojoule per minute on day 1 to 4.53, from 3.97 to 4.53 plus minus 0.9 kilojoule per minute on day 3. P is lesser than 0.05. The increase in resting energy expenditure was associated with an increase in the norepinephrine concentration. How about that? And then alternate day fasting in non obese subjects effects on body weight, body composition, and energy metabolism. Even in this study, when these individuals were doing alternate day fasting, which resulted in average daily increase in fat oxidation of more than 15 grams. What was the design? Non obese subjects, 8 men and 8 women, fasted every day, every other day for 22 days. Fat utilization more than 15 gram. So fat mobility increased because there was no insulin or less insulin, and the body needed energy, and the body said, all right, take it from the fats. So please, once again, I'm going to repeat this one part. If you increase insulin by eating things that can increase insulin other than glucose or even glucose, if you increase insulin and then you expect storage to be melted, that's not going to happen. For example, in Dr. Korki's paper, she talked about iron. She said nowadays we are eating meats that are too refined and cleaned and have more iron. Our animals are healthier. Our animals have better elements in them as well. And iron causes insulin release. So she gives examples of other foods as well. So some tips. Don't eat naked carbohydrates. That is when you mix something with them. Take carbs at the end of the meal instead of the beginning. If you take carbs near the end of the meal, they actually get mixed with the other parts of the meal, proteins and fats, and their glycemic index reduces. They release glucose slowly. Walk right after you have eaten carbs. So think about it. What would happen is as you eat carbs, you're going to create a spike of glucose, which would also cause a spike of insulin. Then, so imagine if I did that during the lunchtime, and now I have glucose spike for a couple of hours. Then I said, I'll go in the evening and walk. Well, that glucose spike that was out there stayed there for 2-3 hours, did its damage. And now I'm going to go out and walk after 4 hours. I let the glucose do its damage. So if you are going to eat glucose, if you feel I cannot hold it for whatever reason, you want to eat it, or it's some circumstance, you're sitting with family or friends and you have to, then when you have the glucose and insulin peak, that is when go and move, so that body, instead of storing it, uses it and done. So that's important. Fasting is the best method. We've talked about it. Unprocessed carbs are very good as well. Less processed carbs. And then puberty has more glucose and more insulin. Don't try to fix that. Similarly, women during pregnancy also have more insulin and glucose, but they should talk with their OBGYN to figure out is it troublesome or not, because the baby needs glucose to develop. Of course, baby should not get extra glucose because then it becomes too bigger and there are problems. So that is when they should talk with the doctor. So this is the discussion. I hope it was useful. I will do a complete series on how to manage diabetes with these kind of evidences, and I'm going to cut them down into smaller 10 minutes chunks. Now, number one. Number two, as I said, there is a anonymous Cool Bean who has invested $40,000 in Dr. Bean to produce diabetes lectures. These lectures will be produced by Dr. Priya Jayasinghani, who used to appear with me on YouTube as well. So she will be tasked with this investment to produce diabetes lectures. So my request to you is that if you are interested in them, I think we all should be, then get access to Dr. Bean. I promise you that our course pages are now at the end of their testing, and we would go away from the $67 or $97 price. So if you want to get access to these things, this is the time to get in. And if you would like to invest in building some other component of Dr. Bean's lectures, for example, emergency medicine or lectures for hypertension, you are welcome. You can join as well. And with that, thank you very much. If you would just like to support my work, there are links in the description. You can use PayPal, you can buy me a coffee, or you can become part of Substack or Patreon. And the least but very appreciated I can do is if you can like, subscribe, and share. So with this, I also need your comment. How was the setup today? Was the audio similar or different? And please tell me about that. And I would see you tomorrow with Dr. Keith Berkowitz. Bye bye for now.